Good morning, ladies and gentlemen. I have no idea what he said. I hope it was good. I don't know, it could be bad as well. But it's very nice. I've been here 5 years ago, and I really enjoyed my time and was treated very well. And that's why the reason why I'm back here to share some thoughts with you. Can I just see how many participants need translation? Can I just put up your hands? I just want to see, do they understand? How many? Okay. Because my Russian's not so good, so I'll have to speak very slow. And my lady at the back will help us. Now, I'm very happy to see that there's some very experienced surgeons amongst us here, and then there's some younger surgeons, because I'm starting this program today with very basic stuff, how to manage the management of an orthognathic case. Because sometimes when we go to courses, we see all this fantastic new developments and difficult cases and how to handle them, but we forget about the basic stuff. How to basically examine a patient and for the things that we need to look at. So we are very fortunate to work in this area of the body. Just imagine to be an endodontist with a little file and drilling the mesiobuccal root of a tooth every day, and we have this wonderful topic that we have to work on. And the thing about the area where we work is it's the face. Everybody sees what we do. So I often say, if we in our work, we don't change faces, we change lives, because everything that Cicero said before Christ, he said, everything is in the face. So some years ago, and when was it? In 2007, I read this article, and I thought by myself, a little offended, because we as orthognathic surgeons and orthodontists, we are very much inclined to concentrate on angles and lengths and how to analyze a face, and we forget the clinical stuff, the art of examining a patient's face clinically. So I read this and I thought that anthropometric data should be ignored in surgical planning, and I thought, wow, I don't like that, you know. And then I look at Arnett. Arnett's a very good friend of mine. But I think sometimes if I look at all these lines and angles and green numbers and yellow numbers and blue numbers, we're not treating numbers. We're not treating x-rays. We're not treating an analysis. We're treating a face. And then I think an orthognathic surgeon should develop, apart from these numbers that we'll look at, an art to analyze a face. And you know, I say to my students, if you're a soccer player and you want to practice, you go to the soccer field and you kick the soccer ball, or you're a tennis player, you have to go to the tennis court and hit some tennis balls, or you've got to go and practice. An orthognathic surgeon, you don't have to. You go and sit in the restaurant, like last night, and you look at faces. You know, you just sit there and you say, nah, open bite, vertical excess, concave profile. You know, you practice by sitting, you can sit in church and just look around and practice. And see, if you look at a face, what occlusion do you think that patient have? And in my practice, my private practice, if I go and meet my patient in the reception, by the time we sit down, I've already made my diagnosis. I already know what the occlusion looks like, or what kind of occlusion do I really would like to have. So the rules are for the guidance of wise men and the obedience of fools. So sometimes I do a fantastic, beautiful case, and I really am happy. And then my students say, yeah, it's a very nice case, but you know, SNA is still 70 degrees. So what, you know? Has anybody ever told you that your facial contour angle is a bit too much? No. You look at the face in general, okay? So I think a surgeon, orthognathic surgeon, should have the eye of an artist and the mind of a scientist. Okay. And then I saw this article as well. Is it me? Are you there?
No, it's fine.
Okay. I thought I'll have to stop. It's a short lecture this morning. The error in this approach is that normalcy is synonymous with beauty. Because all these numbers, the facial contour angle, rickets, Downs analyses, are averages of faces. That doesn't spell out beauty. The beauty is the harmony of different parts of the face. You know, and sometimes I look at, I often say to my students, if I give you 5 objects and I ask you to make 7 billion different shapes that you can recognize, they'd say I'm crazy. But when God made us, 2 eyes, a nose, 2 cheeks, a mouth and a chin, and the shapes are just differently positioned, and we can, today I can recognize every one of you, but you only have 5 objects that I'm looking at. It's amazing, isn't it? So the art suffocates the scientist, but the artist must have fresh inspiration. So therefore, learn as much as you can and make that the basis of your art, the science, but a little less science and a little bit more art. So you have to develop to become an artist. Okay? So orthognathic surgery is a science and an art. My last lecture tomorrow afternoon will be, I don't know if we changed it, I don't know if we've changed it, will be this question: is orthognathic surgery a science or an art or both? And I like that lecture because it's a little bit of a philosophical lecture. And this book is written by a genius, which I think you should all have. It's the basics of orthognathic surgery, and I hope you all have it. So, in principle, what is orthognathic surgery? It's a combination of tooth movement and jaw movements. And we, as orthognathic surgeons, we can move jaws, and we have this wonderful. How many orthodontists are? Can I just see orthodontists in the audience? 1, 2, 3, 4. Hey, they've increased the IQ of this group by 50%. But it's lovely. You know, that's the one thing about orthognathic surgery, is that it. We have a saying in South Africa. It says, sorrow shared is halved, but the pleasure shared is doubled. So the nice thing about orthognathic surgery is I can share my case with my orthodontist. You know, I can phone my orthodontist and say, Ken, that was a nice case. Thank you for aligning those teeth so nicely, or thank you for preparing the case so nice that I could do my surgery. Isn't it? But if you're an endodontist and you sit there with a file the whole day and you go back to your wife and say, oh, I did such a nice mesiobuccal root this morning, you know, it's nothing, absolute nothing. in any case, that's the way I think. So here's the basics of orthognathics, the goals, the treatment goals. Facial harmony, aesthetics. We want function. We want our result to be stable, and we want the patient to have an airway. If we can reach those goals, we'll be fine. And I sort of say this to my orthodontists and my colleagues: think soft tissue. Think soft tissue. Don't look at the teeth first. When the patient comes into your surgery, look at the soft tissue. You look at the patient. See the way they talk, the way they smile, the way they pull their faces. You know, sometimes how they say hello to you. You know, all those things. Look at how big is the patient, how fat is the patient, before you look at the teeth. Because we can control the teeth. But we want the end result to be a nice soft tissue result as well. So don't forget about the soft tissue. So how can we treat orthognathic cases? Okay, patients, we can growth modification, which I personally have my doubts about, because it's not that important, not that much. We can do orthodontic compromise, which sometimes drives me crazy, I'll be honest. Because if I see a patient and the patient comes in and said, you know what I hear, can you hear me? Sorry, I should be here now. You know what really drives me crazy is if the patient comes in and I say, how long have you had orthodontic treatment? 5 years. And what did the orthodontist say? The orthodontist said, he did everything he can now. Now it's up to you. So what I hear basically is, I've compromised as much as I can, please help me out here. That's what I hear. Am I right? And you know, we as surgeons know, once you've had a compromised case, it is a disaster, because I am the guy who has to tell the patient, I'm sorry, you have to go back to your orthodontist and decompensate. Redo your orthodontics, which is bad news. And then we have a box of tissues there in front of us. So orthognathic surgery growth modification can be done in the growing phase, obviously, when the patient's young. Distraction we can do any time that we would like. Okay? Orthognathic surgery in the females, we'd like growth to be completed. I personally would operate girls a little earlier than males. Because and most of the times, the girls stop growing before with the boys. Obviously, class 2 cases, I would operate earlier. Class 3 cases, later. But I'm going to qualify that. If I see a patient with a class 3 occlusion, and I'm convinced that the maxilla is deficient, I'll operate the case earlier. Because that maxilla that's deficient in growth is not going to wake up one morning and say, oh, I'm a little bit behind. I'm going to now grow faster than the rest of the body. It doesn't happen. It will, if it's deficient, it's going to stay deficient. It's not going to start carrying. Now, I saw this by Sava Prophet and Ackerman. Now, can you see that I've got some question marks there? Because I think that, this 25 millimeters, how many times have you moved a lower jaw 25 millimeters? I don't think I've ever done that in my life. Look at this, 15 millimeters vertical. How many times have you done that? I've done orthognathic surgery for 43 years. I've done 9,000 orthognathic cases. Never in my life have I done 15 millimeters or 15 here. So this picture, not too sure about it. Not too sure about it. Okay, now what does compromise mean for me? Compromise means that we need to treat, but it must be not beyond the biological parameters. God has given us some biology where we say, you can move a tooth that far, but if you move it further, it's not going to be stable. Or I can move a jaw that far. But if I move it too far, it's going to come back a bit. Okay? So, now I sometimes get this kind of thing. This is a prosthodontic compromise.
Stop.
Can I must tell you a story. Can I tell the story? I'm sorry. I promised I won't make jokes. And I think the guys that know me know I like to make a few jokes. I was invited to speak the first time in my life, many years ago, at the American meeting. Big meeting, there's like 2,000 people there. And I'm very nervous because it's the first time. So I bought myself a new suit and a new tie, shoes, sort of like, I believe that if you're not good, look good, okay? So it's my turn, so I go up to the stage there, but I have this thing, the microphone like this with a thing, with a little box that I have to put here. So I go up there, and the guy gives me the box. I want to put on my suit, but my new suit is all closed. So I don't have any place to put the little box. So I said, don't worry, I'll put it here between my legs. I'll do it. He says, no. So then I said, okay, I'll put it here, yeah. So I put it in my pants here. But as I go, this box falls down into my pants here. So I'm walking like this, and there's 2,000 people there, and they thought I was dancing a little bit. So the trick, my tip here for the lecture, always if you have a new suit, open the pockets. Okay, that's the big tip. Doesn't matter how good your lecture is. Anyhow, sorry, I'm deviating. This is bad, obviously. This is a bad compromise from a dentist. Or we can get this kind of, remember, we're not treating teeth. We treat a patient. We treat a person who's got teeth. So with our growth modification, we can, in some cases, make some difference. In my opinion, not much, but it's a compromise, okay? So sometimes you could say the models on the table looks fantastic, and say, okay, Mrs. Jones, I know you don't look so great, but look, the teeth fits, huh? It's nice, huh? So we don't want that. Or this patient here, can you see this severely convex profile, big compromise, upper teeth back, lower teeth forward, and now if you put a pilot in there, then you can fly with this patient, because it's like a jet. Or this one here, can you see there? It's also not very stable. Look, it's a little open there, but look at this, and it always reminds me of this. Look. We make Boeing jets. We're not making patients. So forget about compromise. Or this, I call it the ripple effect. It goes, but the teeth fits. Or here, can you see what's happening here? No function, no stability, and aesthetics compromised. We don't want that kind of thing. And we also we pay a price by periodontium. Look how far that teeth are forward there. So that kind of compromise we don't want to. You see, we need to do some grafts and then correct it. And so we are forced to do certain things that we don't. Or patient information. Sometimes the orthodontist, with respect, is not used to modern orthognathic surgery. When the first case I did in 1974, I did a sagittal split. It took me 4 hours, 2 units of blood, patient intensive care for a day, teeth wired together. Now, Andre, sagittal split, you were there 40 minutes, 30 minutes, finished. Patient goes home. So orthognathic surgery has become very easy and technically easy. If that's why we're here, we want to become like that. That's why we don't want to do it the way we did it in 1974. We want to be, I'm so happy to see so many young guys here. Really, I feel so enthusiastic if I see that, because I think in a few years' time you're going to do it even faster than that. But it doesn't matter how fast you do it, as long as you do it well. That's the important thing. So I have in my practice a little information for every procedure. I have a little information sheet where we inform the patient, because the best patient in the world is a well-informed patient. If they understand, and they become very easy. Like this guy, I must tell you a story about this guy. This guy, I came into my practice and I walked into reception and he's sitting there, and I thought, my God, this is great. I want to see you quickly, you know. So I say, come in, my friend, you know, because I think I've made the diagnosis there, you know. It's not difficult, is it? So he sits down, and he has a letter, a referral letter. So I said, who's your dentist? He said, Dr. So-and-so. So he said, he gave you a letter? I opened the letter. You know what the letter says? Dear Johan, please remove the wisdom teeth. My God, you know, so I said to him, okay, but tell me, how do you feel about your profile? He said, oh, I hate my profile. Oh, I can't live with it. I don't go to the restaurant, because if I eat spaghetti, it comes out here. And so I said, and your bite? He says, you can hear that I talk like this. I don't really communicate. So I said, what did your dentist say about your bite? He said, he said, it's the most interesting bite he's ever seen. Now, you see, that is poor information, am I right? Anyhow, we did him many years ago, but we were fine. So the main thing is, look further than this interesting bite than we have, okay? So here's surgical compromise. Our plastic surgery colleagues, they love a chin implant, but they do it for patients with mandibular anteroposterior deficiency, not microgenia. A patient with microgenia needs an implant, needs a genioplasty in my view, not implant. But anyhow, so this is no good. I mean, look at that chin. It's a horrible chin. Do you agree? Or you know what a chin implant does. This implant goes right through into the bone, and it's loose, and it moves. You know, when a patient goes out for dinner, he puts his tie on, he puts everything right, and he makes sure his chin is nice in the middle, you know, and then he goes out. It's crazy. Sorry, I'm going before you miss. Are you okay? Okay. So then we took the implant out and we did proper orthognathic surgery, and obviously that's the answer. Patients, a genioplasty is not a substitute for mandibular surgery. Okay? Here, the famous Hugo Obvergieser, who passed away a year or two ago, he didn't like it. He described the double sliding genioplasty. You know, the cephalometric analysis tells me pogonion must be on this line. So I move the chin forward and I see I'm not going to make it. So I make another slice and move it even further forward. But now I have a gear lever, you know, for the car. Like you want to change the gear with the chin. It's a big thing. But then, you know, if we do it properly, we reduce the chin again and we can fix that. Oh, this patient had orthodontics already, but that's an open bite case. And we know that a skeletal anterior open bite, the orthodontic correction of a skeletal anterior open bite is not stable. The patients need corrective surgery, okay? Or this patient had, you know, in South Africa we have dentists or stomatologists, is that what they, in your case maybe, They have over a weekend, they have an orthodontic course over 1 weekend, 3 days. Monday morning, he's an orthodontist. He buys the brackets, puts on here now. Then we get this. Like, this is a dentist treating patients, So we've should provide the patient with all the treatment options, and then before we start the treatment. And it's so important in my practice that before the orthodontist starts the orthodontics, that I see the patient. So that I can inform the patient, number one. The patient sees me, sees I'm just a normal guy. I explain things nicely. I give him the option. I never say, you must have surgery. No, I say, this is the best option, but you can have this and this, but I recommend you have this. And that's the first advantage. The second advantage is I have a say in the treatment plan. I can say to the orthodontist, my friend, I'd like you to deviate the roots. We want to do segmental surgery in the maxilla. I want you to decompensate the incisors, level the occlusal plane. We'll talk about it during the next 2 days. What the interrelationship between me and the orthodontist, that's very important, So, in the beginning, I'll tell you, when I started in 1974, I phone and say, hello, John, just align the teeth, I'll fix the jaw. That was the treatment plan. Not good, okay? So the team approach is the orthodontist and the surgeon with the dentist and medical practitioner is the same thing. So in my view, we need to see, when the patient walks in, I look at the patient. If I look around here, I'll say, what does he need? Does he need a rhinoplasty? Does he need nothing? Does he need a chin? I've already analyzed the patient. Then, what is expected? You must ask the first question that we ask. In fact, this afternoon, Andre, we're seeing the patient this afternoon. Yeah. The first question we ask the patient is, what's your concern? What bothers you? And you don't want to hear, my mother says my chin is too small, or my boyfriend says my lips are too thin, So you want from the patient's view, and we have to address that, number one. That's the first thing. We will see other things. You'll see this afternoon when we see the patient, we may see other problems or other things, how we can correct the other problems that will help us correct the whole facial pattern. Then, why is treatment required now? Why does the patient come and see you when she's 38? When she's 16? Okay, so we can use obviously all these other people to help us, but the main players and the team is that. So I'm going to go a bit fast now, because this stuff I don't have to tell you what we're going to look at. We're going to obviously get a medical history, dental history. We'll look at the patient frontal profile, three-quarter view. But you can see there, the occlusal evaluation is after I've done the clinical facial evaluation. Then joints, very important. And then only do we look at the x-rays, the CEFs, or special investigations. In the hospital, sometimes the students say, would you like to, I'd like to show you a patient. Then I say, fine. Where's the patient? Then he takes the CEF out, so it shows me the x-ray. I say, where's the patient? The x-ray is a copy of the patient. Have you seen in your practice, I'm sure you've seen this, the patient come to you, and they're sitting in your reception with the father and the mother and the patient, yeah? And you know who the patient is, no? And the father is holding a box and an envelope, okay? And you know what's in the box, no? The models. And you know in the envelope is a cephalometric radiograph and a panorex. Am I right? You know that. And now when they come to your office, into your office, he walks like this. Because the secret of his son is here in this box. So he puts it down. Now I start talking about the weather, you know, and how you're doing, and, you know, make friends with the patient. But they don't listen to me. They want me to open the box first. Because then I say, what did the orthodontist say? He says, we're very worried about my son. Why? Because he's a 15 degree. So I said, what? Is he going to die? Because he's got 15. Does he need to be 16 degree? Because one of the angles are out. And now I say to them, I know, don't relax. I know in the box is the models. And they think, yeah, this Reyneke is good. He hasn't opened the box and he knows there's models in there. He's clever. And I say, in the envelope, there's 2 X-rays. Unbelievable. This guy is very good. Yeah. So I said, relax. These X-rays and the models is the copy of your son. But I've got your son here. So why, let's look at your son first and we'll look at the copy. Because we spend too much time with this stuff here. It's important. I'm not saying it's not important. But look at the patient first before you go any further. So this is the sequence quickly. We do take a history, we do a clinical evaluation, then we do our special investigations, we make a diagnosis, and then we, with a problem list, then we have treatment objectives. That means, what do I want to do for this patient? Then we develop a VTO, which we this afternoon for our patient. I'll do one for you today. And then we have a plan, because you have to have a plan. And the plan must be known to the orthodontist and me and the patient. That's important. So, general patient evaluation, obviously, we need to know that the patient's got diabetes or rheumatoid arthritis or liver disease or medication, all that stuff. You know, this is stuff you know. I'm not going to tell you much about that. And then we go through this, and then we have diagnostic records. We have to have a record of what we say. So this is the sequence. We have a plan, make a diagnosis, we do pre-surgical orthodontics, and now surgery first. That's the Eastern, like Taiwan, Chinese style, surgery first. My philosophy about surgery first is very small indication, very small. We can spend time about that. I have a whole lecture on that, but it's not for today. But I'm telling you now that the only advantage of surgery first is the surgeon gets paid first. Post-surgical prosthodontics, then rhinoplasty, and then retention, they call. So that's what the sequence look like, okay? So, dental, this is stuff you all know. I don't have to show you these things. That's important, and make sure, especially for us as orthognathic surgeons, is if I discuss my plan with the orthodontist, I'm not going to extract a healthy tooth and leave a tooth with a root canal treatment just behind it. You know, that's stuff like that. So we have to talk the same language about that. So then, general patient evaluation. We're not going to, patient that's on the waiting list for a heart transplant, we're not going to do orthognathic surgery for him, all right? This is an interesting patient. For instance, the patient was sent to me for the correction of facial asymmetry. And I thought, wow, this just doesn't look right, you know, because he had a good occlusion. And then I sent the patient to for radiology, and it says isolated fifth nerve degeneration, but he had a brain tumor. Now, just imagine me as an orthognathic surgeon gets the patient beautiful, but he's still got a brain tumor. So don't slip up with medical problems. Or a rheumatoid arthritis patient as well. Look at the patient's deficiency there. I'll show you tomorrow or today about open bite cases, how we've corrected this patient's jaw. And then obviously periodontal situations is very important for us because the orthodontist needs to move the teeth. And we need healthy gums. We need to make sure that we don't run into trouble there or like there. We now are going to tell the patient, I want to decompensate the teeth. Can't move those teeth further forward. We'd rather move them back. Or a large tongue. Today we'll talk about a tongue reduction for open bite cases. So look at the tongue. Don't forget about the tongue. It's important. We'll talk about that as we go along. And also the psychology of the patient. If the patient says, what's a problem? I say, what bothers you about your face? Everything. I hate myself. Not a good orthognathic case. Yeah? Or I don't know. I'm happy, but I can't get this job. I'm second in command. I want to be the chairman of the company, and I think it's this chin of mine that's so bad. If you move my chin forward, I'll become the captain. Not a good orthognathic case. But we know, and we can see, I don't have to show you here, which is the post-operative picture here. You know that this is after surgery on that side, okay? So in that book of mine, I have a very short list of just quickly assess the patient's psycho. Just a little mark and get a feeling for what's wrong or what's not. It helps you fast. You're not going to send every patient to a psychologist or a psychiatrist, not at all. But there's some cases you've got to be careful for. And in my life, I've done 9,000 cases. I tell you, I've had a few in my life that drove me crazy. That's why I'm so grey. I'll show you. I'll talk about it when we talk about facial asymmetry later today. And we can see that we change lives. We don't change faces, we change lives. We can immediately see by just looking at the eyes what the difference is. Or like here, look at those eyes, and we can see which one is the post-op. Those eyes, the light has gone on. They're happy, and it makes you feel happy. You want to be at night when you go to bed and you put your head on the pillow, you will say, yes, that's nice, and the patient's happy. That's what you want. And you get these letters. I'm give you, in all my years, you get a letter like that. And I've done this, I put them in a box. And if I have a bad day, we all have bad days. I go to the box and I just read 2 or 3 of my little cards, and then I feel good again. So save your letters if you get them. They're good for your psycho. You need it sometimes. Okay, beauty is the balance between the spirit, emotion, and appearance. And I think the appearance plays a very big part in that. These 3 factors exist in each other, but influence in each other. They influence each other. And we want a happy patient. That's what we want. I want to show you this, guys. This guy came to see me. He was a real nice man, but obviously not the greatest profile in the world. But he had a massive class 3. And then he sent me this picture 3 or 4 years after he had his surgery. You see, orthognathic surgery can also affect the biceps and the triceps and the trapezius. So it does make the patients happy. So keep that in mind. Now, growth is very important. Obviously, we don't want to move a jaw when the patient's still growing, with a few exceptions. Maybe and we need to examine. This patient here was 13 years old, 13, this massive class 3, and very unhappy. Didn't want to go to school, no friends, didn't like the life. Now, she's 13, obviously she's still growing, am I right? Now, according to the book, I need to say, you're still growing, take off your braces, put you under attention, go home, come back when you're 18. Now, in my mind, for a female especially, from 13 to 18, extremely important years of your development of your whole life, of your personality and your character and your confidence. So, in my whole life, I think 7 times, I've operated on a growing child. Because I said to this patient, listen, you're still growing, but I'm prepared to offer you the surgery now, but I think when you're 18, we may have to do a small correction, because that's the choice. And she said, let's go. So we did her surgery, and when she was 18, I did a small correction by just advancing the maxilla 3 millimeters, I think, or 4 millimeters. But I had a happy patient. So I think, according to the rules and to our science, we need to wait until the patient's finished growing. However, there's a few exceptions. And then where the psycho comes in as well, where you need to see, I'm going to offer the patient the surgery or not, okay? So let's look quickly at the aesthetic evaluation. We have to, when a patient comes in, you have to do it within your mind. What do I want to do for this patient? What bothers me, not the patient? So we look at harmony. Don't play the number game. Don't let the numbers drive you crazy. The numbers will confirm your clinical diagnosis. Clinically, I will, I like to, my diagnosis must tell you what the patient looks like. I'd like to say, imagine, I'm going to tell you, I have a patient's got vertical maxillary excess, mandibular anteroposterior deficiency, and microgenia. Can you see the patient? But if I say vertical maxillarism, micromandibulism, doesn't tell me much. Mandible, I don't like those words personally, because I like my diagnosis to tell me what the patient looks like. So make it simple. Just keep it nice and simple when you make the diagnosis. And then once I've said that, I would say, obviously, now can you imagine the occlusion? Class 2 anterior open bite. Huh? That's about what I'm seeing. Am I right? That's the patient that you see. So now we're going to look at the patient from the front, the 3/4 view, up and down, and we're going to look at a profile. One of the first things I look at is mentalus action. That patient that walks like this all the time. So immediately I know, why is the patient doing that? Because he's got an increased interlabial gap. So this is what Cannon and Doyle said about Sherlock Holmes. Sherlock Holmes said this to his assistant. I see, but you see, but you don't observe. So you must know what you're seeing at, what you're looking at. So you've got to see and observe. Make the note of what you're gonna see. Like this patient. This patient's got Marfan syndrome, long face. He's like a big guy like this. This guy's strong and wide. But if I treat this patients to the normal numbers, they're going to look like E.T. with a little round face on this guy with a long, he doesn't want to be that short because he's a tall guy. So you've got a MAC, I've got here at the bottom, I call it the corporocephalic relationship. There must also be a relationship between the body and this patient here. I mean, I look at his eyes, I look at his face. What on your left-hand side, what do you see? Sleep apnea, no doubt. And on the right-hand side, this is what we want to see. We want to see a nice separation between the jaw and the neck. And these things you can find in any book, any orthognathic book, all these lines, the fifths, the eyes, the width of the nose, the width of the mouth, etc., etc. And we'll divide the patient into, we want to see a nice tapered face. And here comes another important thing. Andre was in Korea the other day, and we talked a little bit about the differences in faces, in Korean faces, Eastern faces, Chinese faces, Taiwanese faces, and Caucasian faces, European faces. But my last lecture tomorrow, I've got some philosophy for you about faces and the development of faces in the world, evolutionary-wise spoken. So we've got to look at the width, and we have narrow faces and wide faces. In some cases, the width is abnormal, and we, like the patient here, can you see the big masseters here? And we can do the correction for those patients if it's abnormal. But often patients with big, strong guys, it's got wider faces. Men, it's got wider faces than females. So we've got to look at patients with hemifacial microsomia. Big, we've got to distinguish between hard and soft tissue deficiencies. Is the bone like that? Is it the soft tissue? This guy's got no masset or no temporalis. We'll talk about it this afternoon. And then the thirds. It's in the book. You don't need me to tell you about this. Thirds. For me, an important part, and we'll talk about it tomorrow when we talk about genioplasty, is labiomental fold. There. Where should that fold be when we do genioplasties? But the rest is easy. But the problem here is this part we can't treat. The upper third, we need a neurosurgeon to change that size. Am I right? But sometimes I say you have to have, look, you see, the hairdresser is your friend. Because the upper third can be controlled by the hair. So you ask your hairdresser to just cover that for me a little bit, okay? Or this guy, look what happens when we do orthognathic surgery. Look at the hair, But tomorrow, today, we're talking about open bite cases. I'll show you some interesting things. Middle third, this is where we control more. The interesting thing about orthognathic surgery, the basic orthognathic surgery, is the middle third we can't change a lot, except like for a high Lefort 1, or maybe then to Lefort 2 and 3, which is more craniofacial surgery. But the middle third, not that much, but it's important diagnostic part. You will ask my, are you okay there? She's fantastic, that's cool. Now, this is a little tip that I'd like to give you. I don't know, you may know it, but it's called the cheekbone maxillary point nasal base contour. That contour here of a face is important. When you look at a patient, you don't have to draw it on every patient, but you look at a guy or a patient, and you just look at that line and see where is there a break in that line. Like you'll see this, like this patient. Can you see there? Then I know, because sometimes you're not sure, should I move the maxilla forward or should I set the mandible back? Where's the problem? It helps you a little bit by just looking at that. Where's the dip? Is there a nice continuous line? Or here, can you see there's a double dip? So this guy most probably will have double jaw surgery, while the other guy would have possibly need just single jaw surgery, possibly. But it gives me an idea. So these lines, like this one here as well, and there. You see that it helps you a little bit. So use that line if you're not too sure. Or here, by looking at the amount of sclera the patient shows, it tells me about the design of my surgery. On that guy there, his whole midface is very deficient. So I'll most probably design my surgery like that. On this case, he's got a strong nose, so I'll possibly do a modification on the Lefort 3 and leave the nose and just bring the rest of the face forward. So by looking at the soft tissue, it helps me in the design of my surgery. Or here, obviously, this is a patient that shows no teeth. Now, last night on TV, there was a girl, beautiful girl, but she looked edentulous. She a presenter, beautiful, everything's perfect, But I looked at this mouth and there's no teeth there. I think if we could find the patient, we must find that girl and offer her a Lefort 1 osteotomy for free. Huh? On the next course, Andre. Anyhow, so we want to show more teeth by bringing the maxilla down. That's the key. The key is, and we'll talk this to the case we're going to operate tomorrow. Very interesting case because that's what it's all about, your tooth-lip relationship, okay? Like that maxilla is too short and we need to bring the maxilla down. So by just looking at the patient, it's fine. Now, we as orthognathic surgeons, the nose, we influence the nose, the shape. Tomorrow we'll talk about how we control the nose, the shape of the nose when we do maxillary surgery. Now, the nose, in my days, when I was a registrar, we didn't touch the nose, because that was the plastic surgery or the ENT, ear, nose and throat specialist field, not mine. Today, not anymore. We can do our own rhinoplasties. But we know that if I look at this patient on this side, I'm sure you've seen that she's got vertical maxillary excess. But look at the nose. Wow, you know, very unfavorable for a LaFor-1. So I have to make sure that I control the nose when I do the surgery. Or Binder syndrome. Or patient here, look at that nose, unfavorable noses. So we need to be able to analyze the nose as well. So don't operate around the nose all the time, because this thing's right in the middle of my field. Make sure that I know what I'm going to, how will I control the nose or cleft cases. How can I enhance the nose when I do the surgery? So let's look at the lower part. This part of the face we control tremendously with orthognathic surgery. And we have to distinguish between the various parts of the face. For instance, this patient's got elongated lower third. Why? Because she's got vertical maxillary excess. This patient's got elongated lower third. Why? Because he's got mandibular vertical excess here. So they'll have different treatments, although they both have the same vertical height. This patient's got a closed bite. We open that. We increase the height. Or patient with vertical excess. And it all depends on the amount of tooth that she shows there. That is the secret. Now, this afternoon we're going to show the case, and the important thing here for us is, number one, we know that she's got a gummy smile, that's it. But the amount of tooth that she's showing, I think you will agree that she's showing about 6 millimeters of tooth. And normally we want to see anything from 1 to 4, depending on the facial height, etc. But that's the amount, but we want to see teeth. Now, the amount of gum that she shows there is about 6 millimeters, am I right? So if I treat the smile, I want to move that maxilla up by 6. But then she's not showing any tooth when she's relaxed. And that's worse than a gummy smile. Then she looks like the presenter on the TV, no teeth. So the decision of how far the maxilla should be moved is made on the amount of tooth that the patient shows at rest. Secret. That is absolutely right. Okay? So here's our diagnosis. Increased lower facial height, interlabial gap, increased tooth exposure, gummy smile, normal upper lip length. Here comes it, we'll talk about it as we go along. Maxillary incisors, size, because you'll see that those incisors are, look at that. Not great. We may think of some crown lengthening there as well. Or here, can you see the amount of the gummy smile? And here, she's still showing a little bit of gum there. But at least when she's relaxed, we see. So here comes the 2 golden rules. It is, never treat the smile. And always treatment plan with the lips in repose. You can't make a diagnosis like that. You know, when the patient forces their lips together, you're gone. You don't even look at the picture. You don't know. All it tells you is that the patient needs to force their lips together. That's all it tells me. Okay? So, sometimes, look at this patient. She has a long upper lip. Oh, let me go back. She has a long upper lip. okay? But she's got a gummy smile and small teeth. But there's no interlabial gap. If I treat the smile, I want to move the maxilla up. She's going to look very short, and her lips going to flap all over the world, okay? Like here, can you see? Now this patient here has got nice lip competence. She's got interlabial gap. She's still showing a little bit of tooth. We could even lengthen the tooth, the teeth as well. Now I was in Vienna where Dr. Triaka, I think many know him. He believes that you have to treat the interlabial gap. Any of you been to that lectures that we had? No. Because me and him had a bit of a difference of opinion. Because I say, I think a girl with a slight interlabial gap is beautiful. I think very sexy, isn't it? I mean, that little bit of interlabial gap. We don't treat patients to close the interlabial gap. We treat patients with the amount of tooth showed under the upper lip relaxed. Done. That's beauty. That's what I believe. Okay? Look at these beautiful girls. They all have a little interlabial gap, but it's fine. They're not mouth breathers. Okay? But sometimes you see, sorry, that slide doesn't come out well. But you see, she's still showing a little bit of gum, but she's got lip competence here. Now, if I move that maxilla up a little bit, she will only look good when she smiles. And we don't smile all the time. We don't walk around smiling. We seldom. So we want the patient to look good when they relaxed. Okay, and then the lip size and the lip shape is very important. Look at the Cupid's bow there. Look at this accentuated Cupid's bow. And this patient shows a full upper tooth, but half a lateral incisor. So, when you decide to move the maxilla superior, make the diagnosis clinically, not on the cephalometric radiograph. The reason for that is, if I take a ceph for this patient, I'm going to see the central incisor and the lip, am I right? But I don't see the lateral incisor. So if I'm going to move that maxilla up for that patient, I'd like the lip there to be on the bracket. That's usually a nice guide. But that means I have to move the maxilla up 8 millimeters. But we won't see the lateral incisor then. Only the two front teeth. So rather, I usually say, don't make a mistake. But if you make a mistake, make it long. Rather long than up. Because you make the patient look very old. And keep in mind, when you get older, your lip gets longer. Especially my mother-in-law, when she's cross with me. The lip gets very long. I don't know if she can interpret that one. But anyhow, and then also, there's an ethnic difference. In South Africa, where I come from, a lot of black people, many black people, and the lips are thick. The lips are like a mattress. You can move the tooth a mile and the lip won't change because it's like. So you treat black people differently, and you're not going to treat everybody according to the numbers that we were talking about. They have different numbers. Like here, see the lower lip? It'll curl back. Look. If I advance the lower jaw, it'll curl back. I think I have another slide here. Oh yeah. Sometimes I get a patient like this. Now these lips are like massive, If this girl kisses you, you will never breathe ever again. If the wind blows, it'll give a headache. So when you plan your treatment for her, you may consider the lip reduction. What's it called? I've got it here now. Get it now. Anyhow, can you see that I've reduced the lips? Those lips, at the same time as I corrected the class 2 little midline discrepancy there, I moved it in. And there she's showing the right amount of tooth. And sometimes you get a nice letter and she sends you this, and then you know, I got the lips right, you know, it was fine. Also, look at the contour of the lip. Look at this. Can you see how the thickness there and the thickness there? So sometimes you may need to do a little Genioplasty there. You know, just get it, change the lips shape as well. And in some cases, the teeth are short, and then you can lengthen the teeth by doing a gingivectomy. I do it often at the same time. Look at the buccal corridors. The orthodontist and you must walk that we don't narrow the maxillary arch too much. We don't want to see those buccal corridors. We look at the upper lips in class 3s are thin, and class 2s are thick, but it's mostly rolled out. Look at the difference in the lips now. Look, see how the lips change? But she's showing the correct amount of tooth. She's showing more tooth. Symmetry, very important. Some patients don't even know that they're asymmetric. You know, sometimes I would say, and your chin is slightly off to the left. And then they say, am I skew? Am I that bad? You know, I say, no, it's just part of the thing. And they go crazy sometimes by mentioning something that they didn't even notice in their whole lives. But it's important to note this before surgery, because sometimes, and it happens, we do orthognathic surgery and we make a little asymmetry. You know, we make a mistake. It's slightly off, or the dental midlines are off. And it's so important between you and, of course, orthodontist. Am I right? I see there's an orthodontist. You're the orthodontist now. Are you an orthodontist? Good. Because then I can speak to you. I've got somebody to speak to. Orthodontists are very meticulous about midlines. You know, and if there's anything I do in an orthognathic case, I make sure that midline's right. Because now, I'm sure you've had this before, where you do surgery for the mayor's wife, you know, or your colleague's daughter, or, you know, one of these important things. And you do lovely surgery, and the next morning you go for the ward round before you send them home, and you say morning, and she says morning, and you think, Jesus, and the midline is like 4 millimeters to the left. And you go back and you think, maybe you didn't look, and you say, and how are you? And you look, and yeah, the midline, it's off. Now my tip is, tell the patient immediately, tell her or him, you know, can I have another look? And you look and say, you know what, I see your midline's not right. And I'd like to correct it for you. If you don't tell the patient, you walk back and the whole day, everything you see is the midline's off. You know, you look at anything askew now. You know, you look at your wife and the midline's off, and you speak to your next patient, it drives you crazy. The main thing is tell the patient and fix it. Don't think the orthodontist won't see it. You know, fix it. And that is when we make the midlines asymmetric. So, some years ago, we did some classification. And it's based on where's the asymmetry, what tissues are involved, and what dimensions are involved. Because the face is a 3-dimensional thing. So we look at chin could be asymmetric. We get a combination of these two. We get a combination like this, or we get a combination like this. And then we have to look at the dentition, which is important. The soft tissue. Does it affect the soft tissue, like hemifacial microsomia cases? The nose, orbits, and frontal areas. So the face has got a lot of areas where there could be. Don't miss out an area that's asymmetric that you haven't seen. So, you can draw a line if you like. There's often a cant. And in a case when there's a cant in the occlusal plane, that's one of the things I will tell my orthodontist. Don't correct the cant. I'll correct it, because it helps me. If I do a correction of the maxillary cant, it helps me to correct the facial midline. If he doesn't, or if she doesn't, that's a problem. Or if the mandible is asymmetric, keep the dental midline in the middle of the jaw. Because if a patient's got mandibular asymmetry and the dentist, the orthodontist, aligns the midlines, I'm buggered, I'm stuffed. Then I have to do a genioplasty, which is a compromised surgical treatment. Okay? For instance, here, we want there's a cant, obviously. And the cant helps me. When I do the correction of the cant, it brings the jaw midline and the dental midlines in alignment. Let's quickly look at the, time's flown, eh? I'm going to go fast now. We finished it. We're going to look at, now this is easy. I mean, even a South African can see that there's some problem here. You know, there's some, make a diagnosis at least, okay? So, always examine the patient in repose. Always examine the patient in repose, because look at this patient and this patient is different because she's forcing her lips together. I have no idea what's going on here. Or here, look. You can't make a diagnosis there because this tells me nothing. All it tells me is the patient's forcing his lips together. That's the diagnosis, nothing else. Here, I see vertical excess, a mandibular anteroposterior deficiency, short chin, throat length, etc. We're going to go through it quickly. Always keep the patient's face in what's it called? Normal posture, facial posture. What I do in my cases, I say to because there's various ways you can put something on the wall and say, look there, etc. What I do is I say, do this, and smaller until you feel comfortable. Okay, stop. Take X-ray. I take my own X-rays because I want to see. Because you know when you send the patient to a radiologist or the nurse takes the X-ray, what do they tell the patient? Put your teeth, close your mouth. And then they take the X-ray. It's nothing. You've got to say, put your teeth together, relax with your lips. That's what I usually say. I say, open your mouth, put your teeth together, leave your lips, put your teeth together, right? Then I take the X-ray. Then I know I'm fine. Then I can make a diagnosis. Here again, you can't make a diagnosis. Okay? So, I'm going to go through this fast because this is easy. This is all in books. Frankfurt horizontal, the true vertical, we can all work that out. And we can look at the lengths of the upper lip and the lower lip and the proportions. And here, I put this black arrow here. This is important when we do genioplasties. We want to know, put that exactly. Now look at the lower lip. You'll think there's big exposure. If we advance the jaw, look. The lower lip curls back. Why is the lower lip there? Because that tooth is pushing it down in class 2 cases. That's why the lip looks like this. And the chin shape changes as well. So all these things are in the books. It's easy. The thirds, how long a lower and upper lip should be. The vermilion upper lip, vermilion is usually thinner than the lower lip by 2/3. Where is the vertical excess? In this case, the mandible. Okay? Where's the vertical upper lip? Long upper lip. Keep that in mind when we think of heights of the maxilla and the chin. The typical vertical excess, if you wake me up at night at 1 o'clock in the morning and you say vertical excess, then I'll give you increased lower facial height, increased interlabial gap, too much tooth showing, gummy smile, rotated mandible, the lower lip is curled back. This, you know, it's like easy. It's not difficult. This is the typical signs of vertical excess. Keep in mind that with class 3 cases, the lower lip vermilion is thinner. Okay. Here, the upper lip shows more vermilion in class 2 cases. So it's not an abnormality. It's the lip is a sign of the skeletal problem. Ethnic differences. I said to you about the Koreans and the Japanese. They don't want a jaw like this. You know, African faces. This. Look at the lips. So every ethnic group has different shapes. I believe that in 5,000 years' time, we'll all look the same. We're going to all have the same numbers. I'm sure about it. Okay? We'll talk about it tomorrow. Okay, and now nasolabial angle, that is controlled by the orthodontist. Very much, because what do we see often? Patient with class 2 occlusion, upper 4 is removed, and the teeth pulled back. And what? The nasolabial angle is wide. We don't want that, especially in females. In females, you want, well, in most patients, you want the lips full, especially in females. If they want to be beautiful, they want full lips. Now look at this class 3 case compared to a class 2 case. You see, now this patient had orthodontic treatment, unfortunately. Here's my line that I showed you before, the cheekbone, upper lip, and that's a nice, should have a nice contour. If I look at that, if I draw a line there, see that dip there? Okay, and here, there's the dip. See the 2 arrows. Just gives you an indication of maxilla, mandible, maybe both. Where do I want it? See there? There's a double line, broken line there. Now here, that's it. Can you see this patient's got also? She has a line like that. So what does it tell me? Maxilla and mandible is deficient. We need to advance both. Look, see how that line's changed? There. Okay, by moving the maxilla and the mandible forward. So it helps me. The nose, we spoke about the importance of the nose and how we influence the nose and the nasal shape. And how we could sometimes do, if I do mandibular surgery only, I would do a rhinoplasty at the same time. If I touch the maxilla, I do the rhinoplasty last. Okay? And the amount of nostril show, the length of the columella, all those things we're going to look at. The facial contour angle is important. And the important thing for the face is that the vertical is influences the anteroposterior because of the condyle. If the patient's got, look, a convex profile, normal is about 11 plus minus, females a little more, males a little bit less. Okay? And we'll see here what I mean by the vertical influence is if I've got vertical excess, the mandible will rotate backwards. You see there? Here, if I've got vertical deficiency, the mandible will rotate forwards. Okay? So that the facial contour angle influences the anteroposterior. I'll just go fast through this as well. Mandibular retrusion, increased facial contour angle. Maxillary excess, increased facial contour angle. Here, vertical excess because the mandible is rotated back, increased facial contour angle. So it's 3 different facial deformities that influences the anteroposterior. Okay? And here the same. You see, it's just the opposite. Small facial contour angle because of mandibular excess. Small facial contour angle because of maxillary anteroposterior deficiency. Here, short maxilla, the mandibles rotated close. Same facial contour angle for all 3 deformities. Okay, like this one here. And now see what happens to the facial contour angle. There. Okay. And then we talk about craniofacial stuff when we look at the orbit, that orbit's also involved. And we can see how dentofacial deformities and the orbit. We're talking about craniofacial stuff now. We do Lafort-3s, etc. And these, the position of the chin, the Merryfields Z-angle, that's in the book, all easy stuff. See that angle, 60, because the chin is back. Here, chin prominence, by drawing a vertical line through subnasale, okay, and through nasion. And here we've got Frankfurt horizontal. Look at that, where far the chin is back. But you know, my clinical diagnosis has already been made, so I just draw that line and say, yeah, okay, I know. Now, when I treat the patient, I'm not going to go crazy about. Remember that this is a guide. It's not a law. That the chin should now be advanced to up to the line. It must be up to the line. No, that's all. It's until it's harmonious with the rest of the face. That's what we want. See? So now we know where we would like the chin to be. We'll aim for that. Short chins, chin throat length, obviously class 2 cases. Look at the difference here, class 3 and class 2. These are all indicators to tell me where I should put things. The aesthetic line, E-line, tells me where the lips should be. Now, it influences by the tip of the nose and the pagonium, okay, like here, see, where the lips are, because the position of the chin has changed, okay, they're the same. The lip, chin, throat angle, class 3 cases, it'll be more acute. I don't think this patient needs orthognathic. She needs a diet. She doesn't need orthognathic surgery. Or the S line is another. I'm sorry, I think I'm going a bit fast now for the interpreter, but I don't want to waste too much time because this isn't the book. You just page through it and you read it. It's easy. My main point is I just want to tell you about it, that it's important to use. Look how it's the maxilla is back. That's why that lips are back. Here, the chin is back. That's why the lip is so far forward. So it's not the lips' fault. It's the chin fault, or the maxilla's fault. That's why. Can you see there? Okay. And see how it changes. Now, if I'm not sure, should I operate the maxilla or the mandible, or should I do both? I can block them out and say, am I happy with that profile? Forget about the maxilla. Am I happy with that section if I block it out? If I'm happy with that? Now, I think you agree with me on the right-hand side. I like that. So it tells me, I think I should operate the maxilla only. Lip thickness is important. We talked about it. It's influenced by the age and the race, and also female and males. Now, I want to show you, now from what I've told you up to now, quickly in your mind, just think what you think of that case. In your mind, make your list of that patient. If you see that patient in your office, what would you think as a list of, a problem list? Got it. Okay? Increased interlabial gap. Slight asymmetry. Am I right? Oh, let me go through. So in your minds, now let's see. She's got a, I usually, if I make it, I usually do the broad picture. You know, I'd say oval face, narrow face, wide face, just to give me a feel for it. Then increased interlabial gap. I'm sure you've got that on your list. Excessive tooth exposure. Narrow nasal dorsum. That narrow up here. Poorly defined nasal tip. That nose doesn't look great. Short upper lip. Am I right? Inverted lower lip. Okay. Now, quickly in your mind, just quickly make your list. What you think is wrong. Big picture, convex. Okay? Increased interlabial gap, excessive tooth exposure, mandible is back, short upper lip, obtuse lip, chin, throat angle, and look at this short there, everted lower lip, I'm sure, short submental line, obtuse chin, neck angle, dorsal nasal hump, acute labiomental fold. Okay? That means that fold there is a little deep. Okay. So that's my problem list. Let's look 3/4, same story. Convex profile, deficient chin, poorly defined lower border, prominent nasal dorsum, excessive tooth exposure, and a small chin. Right. Now, careful for an asymmetric smile. You know, sometimes patients smile like this. You know, and make a note of that. Because she'll tell you afterwards, I had a perfect smile, now I'm smiling a bit skewed. So, can you see there? Slight cant of the maxillary occlusion, but I think it's clinically insignificant. Okay, so that's before, and that's after. So, you see how quickly she still needs the rhinoplasty. I haven't got a slide of that, but you see that we've solved our problems. Because if look at the lip chin throat angle, look there. Then here, the amount of lips, amount of tooth interlabial gap, all those problems have been solved, which you have identified. Okay? the joint's extremely important, you know, because you can do the most beautiful surgery. If the joint, if the condyle is not properly seated in the fossa, it's not good. You know, you can do everything nice, but if that condyle fossa relationship's not good, that's no good, because then the patient's got a malocclusion. So I'll go fast quickly. I've got it in the book. I've got a list of stuff that I can quickly pick up if there's a problem with the joint beforehand. And it's important to make sure that if there's a problem before you do your surgery. And if there's a difference, I want to show you a case here quickly. This patient, sister, had a class 3 occlusion and was treated with orthognathic surgery, with a class 3. She came to see me and she said, I'm biting like my sister. Okay? I said, yeah, you've got a class 3, fine. We'll ask the orthodontist to align the teeth and we're going to set the mandible back. Everything right. She's on the operating table. I turn around and I look at my records and the patient's asleep. And I usually like to before I do the surgery, just feel the jaw. It's crazy. I just feel the condyles before I start the surgery. Just get a feel for that condyles. And I look, and what did I see? I see this. So the surgery changed from a mandibular setback to a mandibular advancement. Because this patient over the years has always been doing this. And now that she's relaxed, and she fooled me and the orthodontist. So sometimes you can be fooled with the patient that actually postures their jaw in a position that you don't know. So another evaluation, and now we start analyzing the occlusion, which we all can do by looking at the models and measuring the open bite and the transverse position and crowding, and we can do a Bolton's analysis. Very important for the surgeons to know that there's a Bolton's discrepancy, because if we, for instance, would do multi-piece Lefort-1 osteotomy, and there's a Bolton's discrepancy, you want to leave a space distal to the lateral incisor for the orthodontist. Because if you close the space surgically, the orthodontist is going to struggle to open them up again, because there's a discrepancy. So leave that little space and make sure that you help the orthodontist, because that's why we work together, okay? And then overjet, cross bites, midlines, this is absolute basic stuff. Important thing maybe is if you think that there's a discrepancy, a transverse discrepancy, take the models in your hand, and this is the occlusion there. Now move the model forward until the canines are in good position there. If there's still a crossbite, then you know it's an absolute crossbite. You have to fix it. If sometimes you move the models and the canines are in good position, there's no crossbite anymore. Then there's no need to correct that, because it's a relative crossbite. Okay? Then think of surgery. When are we going to do the implants? I don't like to do the implants. In fact, I don't do implants. I'm too dumb to do that. If a patient would need a single tooth implant and we're happy that the roots are in good position, we can do it at the same time as the orthognathic surgery. Otherwise, I'll do it later. But I'll ask my colleague to come and place the implant, because I'm not too clued up with that. And a typical example is this one here, where we advance the mandible and the patient had implants afterwards. Okay. Now we go to the radiographics. Now only do we look at the Ceph. It's a long way before we start analyzing our records. And we're not the first. I mean, look at that. When people started analyzing faces and doing some kinds of measurements of facial asymmetry. Now I've been looking, you see all Steiner, Ricketts, Wiley, Coben. I've been looking at an angle that I'd love to put my name to. So if ever you find a new angle, please call me. I'll put my name to it, so I can have a Reyneke angle somewhere. Okay, and that's why we have, with cephalometrics, we have a maximum and a minimum. So it's never 82, or it's 80, from 80 to 84 would be acceptable. So there's a leeway that we have in these things. And we have all kinds of videos, cephalometry, and new methods. Obviously, now with this new 3D scans and stuff, it's fantastic. I mean, it's really helped us a lot. But I still feel, we'll talk about it this afternoon, that your hand is... Now, Alex, I spelled your name wrong, I think. It's a K. Is it with a K? Sorry, my friend. Sorry. Alex came to visit me, I think, 3 times. Wonderful. We had real nice times. Once I nearly fed him to the lions in the game park there. I remember that. Anyhow, Alex did this while he was visiting me in South Africa, and we planned this case, and we planned the surgery as well, and beautifully planned. He really introduced me into this new modern way of looking at things. And a long time ago, we can see that guys has analyzed faces and the age of the face, etc. So I'm not going to go into the growth. I'm going to go fast past this, because growth is important. We need to analyze that best fit, and then TMJ, condyle, and I'm going to go fast here. And there's ways of finding out if growth is completed by technician bone scans, etc., etc. Because we don't want to operate like a patient like this. You really don't want to operate, especially patients with condyle hyperplasia. And then the Panorex X-ray is an important one for us, because it tells me where the nerve is, where the teeth are, impacted teeth. When I'm going to do, here's a big cyst. The patient was sent for orthognathic surgery, but there was a large dentigerous cyst in his maxilla. So we're not going to do the orthognathic surgery before we've done that. But it tells me, when I do my sagittal split osteotomy, where the lingula is, where the roots are. Is that I'm going to take the tooth out at the same time or later, root deviations. So there's quite some information that I get. So we get all the way down to the clinic. We made a diagnosis, and we can do a cephalometric analysis. Then we have a diagnosis and a treatment plan. Phew, I was a bit long there. I'm sorry. I'll catch up with the next later on. Any questions?
Johan, I have one question. Сергей Николаевич, если не сложно, проходите, пожалуйста, сюда, пока будет настраиваться. You promote idea of the artistic approach for the treatment planning, and you have huge experience with the lecturing in many countries. What do you recommend for doctors in country like Germany, where very strict control of the cephalometric recommendation for the treatment planning? How you recommend to perform the treatment planning for doctors in this situation?
The treatment plan?
Yeah.
For begin.
Yeah. No. In your practice, you follow the artistic approach. Yeah. You follow the aesthetic.
Okay. Yeah. Okay. When I say you have to have an artistic approach, what worries me sometimes is that we get driven by the numbers. You know, there's some of my, I want to choose my words tonight, there's some of my colleagues that I've seen, and if you treat the patients according to numbers, your patients can look all the same. You know, we don't look the same. The cephalometric analysis and the numbers are a good guide for me. And make no mistake, I do use it. But I think with the numbers in your mind, you have to develop and slowly develop the artistic feel for a case. I would design the surgery, and I'll say, this is what I want to do. And I would come back to my cephalometrics and say, okay, you know what, let me just check this facial contour angle. Am I happy with that? Or I would do a treatment plan, and then, like for instance, when we just started doing rotation of the maxillomandibular complex, the reason why, in fact, I described that in 1989, the first rotation of the maxillomandibular complex. Why? Because sometimes I would do my conventional treatment planning, and I would look at the case and I think, still not happy. I like it. I like the shape of the chin, but I want it a little bit further forward. How can I get it forward? So then I would do conventional, and I check it with my cephalometrics, and I'm happy, or I'm saying, I'd like to do something else. I need another plan. So, and that, you know, so with respect to the German, my German friends, they can sometimes be extremely dogmatic about things, about principles. You know, not you have to do this. This is the only way you may do it. You know, drives you crazy. You know, so I think I'd really like, especially the young surgeons now, to use that cephalometrics to develop your artistic field, to look at a case and say, that's what I'm going to do, that's what I want to do. And you know, another important thing that helped me a lot is I would plan the case, I would do the case, and the most important thing is then to go back now to my cephalometrics. I want to take my planning and put it on. Have I achieved my goals? Because you know, there's a question.
I want to know, do you have any patients who have psychological problems that will increase
Afterwards? Yeah.
After orthodontic surgery, yeah? Which procedure has more chance to this scenario?
I had 2 patients, and out of 9,000, I had 2 patients. I think the 2 patients that had it was patients that I should never have operated on. You know, you can see afterwards, yeah, but now, that was a long time ago. I very easily say to a patient, you know what, I don't think I can help you. I think, you know, you've got to be careful as well when you say, you can't say, no, you're crazy, go away. You know, you don't do that. You know, you say, you know what, your deformity is very difficult, and I think you may need some help. And I think in my situation, I won't be able to treat you. You much better. You know, there's a saying that says, a good surgeon knows when not to operate. Am I right? And those patients, both those patients had vertical excess mandibular deficient cases. And you know, especially one, I thought it was a beautiful result, really beautiful. That's the first thing. Last comment is make sure that the patient have support by the family or the husband or the, you know, if the husband says, nah, you don't need this surgery, nah, yeah, I'm happy, you know, and then she goes home and says, no, I like the way you looked before, this is terrible, you know. That's the last thing. And now for the orthodontist. What you want from the orthodontist. Now patient's been with the orthodontist for 3 years, aligning the teeth. Now she comes to the surgeon for the surgery. And she has the surgery. The first appointment when she goes back to the orthodontist. Now, the patient is like, you know, wonder what the orthodontist is going to say. So the orthodontist must make a fuss. Beautiful, you look great, you know, fantastic, you know, even if you don't think so, just say it, you know. You know what's the worst thing is the orthodontist says, when are you going for your surgery? No, I'm joking, that's too much, but can you imagine what that happens? He says, I had my surgery, you know.